So I want to welcome you back to the afternoon session. The next speaker is our board member, Dr. Marcy Zwelling. She's the founder of Choice Care Choice Care for Patients, and a board member of this organization since its onset. She has been running a program in Washington, D.C. With another doctor where dozens of us come to Washington, D.C. and work with other physicians and the legislature and the legislators in Washington with the help of Pete Sessions and others. And she's going to talk about MACRA and MIPS and what it means to us. Thank you, Marcy.
Good afternoon. How are you all? Good lunch? So I'm going to demystify things and then just let you know that I have Parkinson's disease, and I'm sorry for any slurred speech or anything that you may not understand. Just ask me to repeat and I will be happy to. Just FYI, I haven't missed one day of work, not one. So you can live with disease. But it's yucky being a patient. MACRA, the government at its worst. So my organization, I call it my organization, and that's really not honest. This is a national organization of physicians, and we go back to Washington twice a year, and we actually get things done. The ICD-10 delay was our doing, the MIPS delay, the meaningful use delay was our doing. I'm sorry.
No, it's not you, it's I need to get ready.
Meaningful, I'm short. Meaningful use delay was the grace period was us. We're 3 for 3, and we're going to be 4 for 4 when I finish in Washington on Monday. So what we do is we go back to Washington, and I actually keep my mouth shut. I know, hard to believe, but I do keep my mouth shut. And I invite my colleagues to do all the talking. And then we vote on what they think is the most pressing issue of the day. And then then it's put back in my pocketbook, and I'm supposed to go get it done. So I'll tell you how we got ICD-10 delay done. I called Pete Sessions every night for a month until he finally told me to shut up. He got it already. He said, I know how to do my job. You know how to do your job. Just shut up and let me do my job. Next night, in the middle of the night, it happened. It was in the middle of the night. So this is similar to concierge medicine. Everything's about relationships. Pete Sessions is one of my best friends. I'm going to meet with him tomorrow. I'm meeting with Medicare, the head of Medicare on Monday, to try to execute some of the things that I put forth in front of you. You have the letter that I constructed. It's there for you to read, and we're going to open discussion. So we're not done recreating what we need to do, and I'm here to listen to what you have to say. In the meantime, I'll give you a little education about the yuckiness of the MACRA and MIPS. The intent of the law was to reauthorize CHIP, to eliminate SGR, to simplify the system. The law was actually written by our good friend Mike Burgess, an OBGYN from Dallas, Texas. I called Mike. What the hell were you thinking? He still doesn't know. He still thinks it's okay. Just an FYI, for those, is Mr. Woodall here from this morning? Well, Congress doesn't have a clue what we do. They don't understand and they don't want to understand. So what you have to understand, you have to tell them. You have to have educational, and then of course you have to hope that they want to understand, and you have to hope that they give a crap. They often don't. So it makes it very hard when you're fighting a person who's only there to get reelected, and you have a mission to save people's lives, so they don't run congruously. So in eliminating the SGR, Congress actually thought, because of our illustrious organizations, AAPC, the AMA, CMA, all our other specialty organizations, have been to Congress telling them how awful the SGR was. As if we were sitting at our desk, biting our fingernails, wanting to know what were they going to do to us next. Everyone in this room knew that Congress was not going to give you a cut. They were not going to cut you by 20%. Did anybody lose a breath of air over SGR in this room? Neither did anybody else in the country. So they used that as an excuse to rewrite the whole bill. And of course, a formula is a formula is a formula. The government knows the formula, and it's done. Simplifying the system, of course, if you've read it, it doesn't simplify anything. It makes it all so much more confusing. This reads, most bad government is going out of too much government. I'm into that. This is macro MIPS. This is the time schedule and the fee schedule. Basically, we're on a we're into our 5-year freeze and with a 0.5% increase. The MIPS quality data are going to come into play in 2017. We'll be expected to be up and running. 2017, around the corner. No one is up and running. No one is ready. Neither is the government. They don't have a clue. Have you seen any quality data come across your desk? And then moreover, after they put it together, they will expect us to solidify it on our websites, on our EMRs, to make the investment, and that's a very key part of the picture here. They want us to make a huge investment in something that will have no return on investment for us, none. And of course, when will we know? In 2019. Because nothing comes to fruition until 2019. So all the work we do today is analyzed in 2019. A lot of good that does you, right? This shows you that the APMs come into play a little bit later, and those people who, as you heard this morning, who decide to go into an advanced practice model are exempt from MIPS. So here's what it does. It's very costly, $128 million in additional costs. Here's my point, and I'm going to be brief because I really want to hear what you have to say. This isn't about quality reporting because the government has no right, no means, and they can't possibly quantify any quality in your practice. Am I correct? Right. So what the hell are they doing? They don't know either. But the point is that they're going to try. And small practices cannot afford it. It's not so much the penalty that we can't afford. We cannot afford the investment. We can't afford the investment to go in to try to even qualify. So as you'll see in my letter, I've set aside, I've created, I think, a means for us to get out of it entirely. Many of the metrics are outside our control, and of course in terms of scheduling procedures and timing procedures, some patients do things their way, not our way, etc. You know how that goes. And of course, we should not be punished for the errors and omissions of our vendors. One of the things that really bothers me is that the EHR, do you all use EHRs? Has anybody seen a study where the EHR is beneficial? Anywhere? Nothing. Nothing. Very costly, very time consuming, and it takes us away from our work. Moreover, the EHR companies, the EHRs, I initially was all on board with the EHRs. The opportunity to create a system where we could get data at the point of service I thought was brilliant, but they don't do that. Does anybody get data at the point of service? Does any EHR talk to another EHR? Do they talk to your office? None. And by the way, that is law, but CMS decided not to enforce that law. So the vendors get away with murder. They're making tons of money. Epic is a privately owned company, but Cerner is not. And Cerner and Epic basically run the hospital systems and making billions of dollars on our backs. This refers to the fact they use old data so that when we're told to change our ways in 2019, it's based on 2017 data. Of course, the small practices closed, and of course, I'm sure all of you are aware that in the regulations, 972 pages, our organization read every one of those regs. We put together 2,000 to 3,000 different comments that went to CMS. And the Medicare itself suggested that 86% of small practices will be affected and could potentially close. 86%. 86%. Who does that? Let me create a law that's going to help you, but first I got to kill 86% of you. Crazy, right? It requires all payer data. So this is not just about Medicare, this encompasses all payers. So what you don't know is that with this system, Medicare and your private insurance become one, and all the data becomes one. And Medicare has basically intrusively forced itself into your office to get all of your patient data. Most of it leaving us, of course. It requires physicians to meet, I'm sorry for the misspelling, requires physicians to meet the thresholds of 80 to 90% of patients, or you fail completely. forces officers to spend at least $100,000 before any return on that investment for 2 years. Anybody have $100,000 sitting in their bank account they can afford to throw away? No, of course not. It simplifies nothing. It punishes doctors for caring for the less unfortunate. It favors large practices. Incentives to join the ACOs and the APMs. Only 4 to 11% of physicians will probably participate in the APMs, forcing most of us into the MIPS system. So, my solutions. My first solution is to provide, as you'll read in the letter, is to provide thresholds, below which practices do not have to engage the system at all. So if you do not make $200,000 from Medicare per year, or see 1,000 patients, you should not have to participate at all. Don't open the book, don't do anything. Because it's the investment that kills us. If you look at MIPS and MACRA, and I can answer any question you want right here, I've got it all. The point is that it's like a bowl of spaghetti. You cannot take a single twig out of the pot without messing up everything else. It is so complex, so involved in everything in your practice, including, of course, as I said, your entire payer mix, making it impossible for us to just nip something in the bud and assume that everything else is going to work its way out. No. So you're in or you're not. So that's why I suggested that. The second thing that I suggested you see in the letter is that we force Medicare to allow an APM of direct practice. We force them to agree that we are the better method, and we should be a method that is a choice. I talk to these guys a lot. They like the word choice. Balanced billing doesn't go to anywhere. It's a no-no. They'll kill you. You talk about patient choice, they love you. So when we sell this to Medicare, we have to talk about patient choice, which really we're doing, right? So what I've suggested to them is that large groups do whatever they want. Anybody who wants to participate in MIPS, God bless you. May your sun rise every day. I wish you all the luck in the world. But don't force us. Give us choice. Give our patients choice. And of course, I think practices have to advertise or state whether they engage in the system or not. And if they don't, they should tell the patients that I sell privacy in my practice. I don't know about you, but when I don't bill Medicare and I don't bill insurance, the government doesn't get the patient's data. That's very important for many patients. Sell that. The government, first of all, the data, of course, is not clinical data at all. You know that. It's all administrative data, all billing data, and it's nonsense. How many of you actually spend time trying to get the right code? The right clinical code? Nobody. You get the right billing code. Am I correct? Of course. But the government assumes that it's a clinical code. So everything from the get-go is already misformed, misnamed, misaligned. It's bullshit in, bullshit out. Spending billions of dollars on bullshit isn't my cup of tea. It happens to be the government cup of tea, not just in our industry, but in most industries. And I think we can stop that by just saying, no, we don't participate at all. Most patients still get their medicine from small practices. And we haven't talked about the rural practice. Does anybody here have a rural practice? A rural practice? Rural practices are devastated by this. And we have many hundreds of thousands of patients that will be without a doctor. That is not compatible with what I think and what we think. So the government is going to have to do something. The question is what? And we're trying to lead them. So as I said, my voice is not the one that needs to be heard. Your voice needs to be heard. Give me some of your real ideas, some of your suggestions, corrections to the letter. Let's stand here and talk about it as a group.
Yeah, well, you know, for me personally, I solved it about 19 years ago when I opted out of Medicare. And at the time, they didn't even have a mechanism to do that. We had to create that. And I don't use EMRs. I tried it, hated it, went back to paper, which works better, except of course in the hospitals where I have to use it. But and I use some of the features that I like about it. But I think if we take control of our practices and do it our way, the patients love it. They pay me gladly. They're very glad not to be involved in that mess. And if more doctors did that, they wouldn't really have anything to sell. And I figured that out many years ago. Insurance companies repackage you, and resell them. They don't have a product. We're the product.
Indeed.
So take it and sell it yourself.
So some
Keep the money.
Exactly. Some principles that I think are very important for our organization, and I'm talking about the ACPP. First of all, fixed pricing. Do you understand the concept of fixed pricing, which is Medicare or insurance companies? The concept of fixed pricing is the concept of moving risk to you. You know that, right? So fixed pricing is the concept of moving risk to you, the doctor. You carry the risk as soon as the government or an insurance company decides to fix price. So that's not a concept that I'm willing to accept. I'm not willing to take risk. It's not my job. I'm not an insurance company. Secondly, as I mentioned today earlier, we have to reorganize our thoughts about insurance. Insurance is an actuarial bet. It should be used for patients in a hospital setting or when they're in acute crisis. It's there to protect them from financial risk. It is not preventive care is not an insurable event. Mammograms should not be insurable. They should be accessible and affordable, but not insurable. And that's a concept that's very important. If we assume that concept, we accept that concept, and everyone in this room posts their prices, what will happen to the cost of health care? It will plummet. What will happen to the quality of health care? It will rise. Because we will compete with each other, because I want to be better than my friend Gary. And that's pretty damn hard to do. So I'm going to have to work really, really hard. But that's a good goal. It's a good goal to want to be better than the guy down the street. As it is with fixed pricing, there's no such goal. Everybody gets paid the same whether the surgery was successful or not successful, whether you treated the patient well or not, the insurance company pays you the same. That doesn't make any sense. The healthcare industry is not that much different than other industries. It is not. Patients are buying a product. They're now much more educated about what they want to buy, but it's also up to us to help educate them about the value of the services that they're getting. So for instance, when we speak about genetics, if we can't describe the value of that test, they shouldn't get it. The quality of your practice is the quality of care that you give to your patient rated by them. It cannot be rated in Congress. It cannot be rated by the guy down the street. Your patient is the purchaser of the product. It's for you to define it, describe it, and sell it. It's a business. It is a business. We have to start to assume it's a business. This kills us. Other ideas? I really would like to discuss ideas. I'm willing to edit this letter today and take it back. This is going to Patrick Conway, and Patrick Conway is, as you see, the Deputy Administrator for Integrated Quality in CMS. He's the Chief Medical Officer of CMS. He's Andy's second hand, Andy Slavitt. Andy Slavitt, of course, was a man who worked for United Healthcare. The CEO of United. He's an insurance guy. He doesn't know anything about this stuff, except what he wants to know. And Patrick actually practices pediatrics. He told me he was working in the hospital this weekend. So I kind of consort to his medical side. And I tried to get him to be a good physician and when he makes these laws. And you understand the power of CMS now. A lot of people didn't talk about this morning, but this is huge because Congress really has nothing to say over it at all. The fact that they created the SGR it's like its last battle because the ACA takes all of the authority of Congress and puts it in the hands of the administration. There is nothing left for Congress. If you want to repeal and replace Obamacare or take away its budget, there's nothing for you to do because there is no budget in Congress for Medicare. You understand that, right? The biggest and worst thing about the ACA was the fact that it moved all authority to the administration. HHS has all the authority to do whatever they want, and they are doing whatever they want. I thought you guys would have lots of suggestions. Yes, sir.
Marcy, you may not know this answer, but I don't know it. How many physicians or percentage of physicians have opted out of Medicare, perhaps in our community of concierge physicians? And do you think that this letter is basically saying to them, if you continue to push forward with these measures, you're going to have more and more people, more and more physicians opting out?
To the latter point, absolutely, and that's what I've told them. And it is just a reality. So the doctor can either get out because Medicare allows us out to participate with Medicare without playing, or they force us out. And so how many physicians don't take Medicare? About 4%, not very many.
And more.
Yeah, but it's about 4%, at least as they reported. So,
And more physicians are completely opting out of medicine. I know a guy who's selling Amway.
you can make a good living in donut holes, I hear. Selling donut holes.
Medicine.
So the point here is to be demonstrative. So first of all, you know that Medicare sent out a letter about 2 weeks ago in answer to one of our letters that we had sent them, said, you got to do something because November's coming. So they sent out a letter and they came out with a flexible plan. Did you see that? We can opt in slowly, like it's like the frog getting slowly burned. Stupid. So I don't tell them they're stupid. I have to make nice. I try to make nice, and then I hit them over the head with a sledgehammer. But they're very nice to me, and they talk to me. And our organization has tremendous clout, and I'm looking for everyone in this room to join my organization, or the organization. I'll give you some materials and places to call, and it's free. Come to Washington, D.C., have your voice heard. It's really good.
It is a tremendous organization. I've been with her many times, and we usually meet in the hearing room of the Rules Committee, which is in the Capitol. It's really cool. You can sit in Pete Sessions' desk and hold his gavel.
I have many pictures of you with the gavel.
Have a picture taken of you saying you're the head of the Rules Committee. It's really cool, and the discussions are very interesting. And there's a board of there's an organization called the Physicians Caucus. There's about 16 congressmen that are physicians now that come and talk with us, and we have dinner with them, and we communicate ideas. And this bill that was recently dropped, that was mentioned earlier, the World's Greatest Healthcare Bill, is really a product of Marcy's organization. Amazing work she's been doing in the last few years, and we really thank you for everything you've done. And,
my pleasure.
And
I'm
I hope
not
your
done
health
yet.
improves really quickly.
I'm not done yet. Well,
I know
Bob's
you're
going to
not
help me
done
with
yet.
that.
I know you're not done. And I'm just going to hand this to Mark, to Briskin here, because he has a suggestion.
Good.
Okay, I applaud you for all the great work you're doing for the benefit of our country, community and patients everywhere. One of the very simple concepts behind the direct patient practices is take a number. It's $80, $100 a month. It doesn't really matter exactly what you set it at. The first $80 of expense in a month, like someone's cigarettes, which is about $120 a month, $4 a pack, or one pack of cigarettes, it's about $120 a month. That makes a tremendous difference in terms of utilization downstream. And what we were talking about outside was that if a patient in a country club community of mine or Gary's or anyone's comes in and wakes up with back pain, they immediately want an MRI because their neighbor got an MRI and it showed this and this and this. And there is no price controls when you have a single payer health system that they can ratchet down the reimbursement on all the items, but there's no reticence or any type of barrier to get testing done. It doesn't matter if it's a cardiac catheterization, echo, stress test, what have you, MRI, but the patient has to share in that responsibility. They have to make an opinion as to what they actually want to finance. And a basic fee like $80 or $100 a month, if somebody knows that they can wait a week before getting an MRI, then you'll reduce the number of MRIs by 80%. That's just one example. If you or I want to get a patient of ours an MRI, privately, you can do it for $350. They go into the hospital, it's $3,500. So there's so much waste that is inherent in the system And a lot of it is subspecialty driven, quite frankly. You know, before they cut back on the criteria for stress testing, every patient with coronary disease was getting a stress test every year. So now they said, we're not going to pay for that. So there hasn't been a mass protest from all these people with stable angina to say, oh, I want my annual stress test, with very few exceptions. So the idea of individual responsibility and using catastrophic insurance as the backdrop, as the stop loss for expenses, hospital expenses, surgical expenses, really expensive stuff. But primary care should basically be, for the most part, a fee-for-service affair. And you can do this if you had $1,000 a patient, $80 a year, $80 a month. You can have 1,000 patients in a practice like that, generates $1 million. The physician is still going to make more than the $200,000 that average internists make, even with a practice when you cut down to 1,000 patients. So there's many ways to skin a cat, and I think that this is a great, great letter, and I totally support you.
Thank you. And Rob made some very interesting comments I'd just like to elaborate on, if I may. I'll be quick. I speak too quickly. That's my problem. So one of the things that has happened in healthcare is we have no means of controlling demand. That's because our patients have no piss in the pot. They're just not there to prove, right? But it is our job, if we're going to create a service, it's our job to explain to the patients the value of that service. When they pay for it, demand comes to a reasonable place. So the supply of healthcare, the supply of MRIs, the supply of CT scans, the supply of, you name it, it's completely misproportioned, right? You have more MRIs in Florida because you have older people wanting them and have insurance companies willing to pay for them. Not the reason to sell a service. Why do you need an MRI, Mrs. Smith? Let's discuss that. What is the value? If you have not convince the patient of the legitimate value of that test, they shouldn't have it. And my personal opinion is that we need to take this stand because we need to be the surveyors, if you will, as opposed to the purveyors of all health care. We can actually solve the problem for the government and solve the problem for the world. Legitimate supply and demand in the right places is only done by a free market. It is only done by a free market with educated patients. It's our job because that's the time that we have. After we're done listening to the patient, which is the most important thing that we do, we should be talking to them and explaining these things to them legitimately, and they should walk into a test expecting value, and we should be able to produce that. That would create a whole different system of health care, where everybody's happy, where expectations are met, dollars are transferred legitimately, supply and demand are reasonable, etc.
Concierge doctors are uniquely in the position.
We're in that position.
Call me on my cell phone in 24 to 48 hours.
Exactly.
Call you and say, oh, well, okay, fine, we'll go ahead and do a CT of the chest or what have you. You can do it then.
So, thank you very much. By the way, Hillary does not have pneumonia. She has Parkinson's disease as well.
Of course.
You knew that.
Yes.
Thank you, Marcy. As always, we